again, everyone. My name is Angela, and welcome to the PHA Live webinar, Caring for a Child with Pediatric PH. We're so grateful for you joining us today. Before we get started, I would like to recognize and thank our PHA Connect sponsors, including Janssen with their Diamond Level sponsorship. Also, I would like to mention, as a nonprofit membership organization, PHA also relies upon the support of its members to fulfill its mission. So please consider joining our global network of PH patients and caregivers, donors, and healthcare professionals, and enjoy access to future PHA events, webinars, and publications. If you are a member, thank you. And if you're not a member, please consider joining us today at phassociation.org/join. A few programming notes that we have for you today. This will be a presentation followed by a Q&A. We will have it immediately after the presentation. You'll notice in your toolbar that there is a button that has space for you to type in your questions directly to the panelists. We ask that you use the Q&A button for your questions instead of the chat. It just makes it easier for us to see your questions and ensure that they get answered. Also, immediately following the webinar, so when I end the webinar, there will be a survey that pops up for you to complete. We ask that you please complete the survey so it helps us to determine what information you would like to see in future presentations. So without further ado, I would like to welcome and thank our panelists for being here today. We have, of course, Jayna Wall, Jeff Harpp, we have Melissa Magness and Dr. Rachel Sullivan joining us and leading this great panel. So without any more hesitation, I will give it over to Jayna to quickly introduce herself. We'll go down the list and we'll get started with the presentation. Jayna?
Hey, so my name is Jayna Wall, and my son Jackson was diagnosed at 14 months old with idiopathic pulmonary arterial hypertension. He will be turning 12 tomorrow. So we have been on this journey for almost 11 years now. And we have homeschooled for about 8 of those years, but we just recently enrolled him in a private school. So we'll be seeing some new challenges this fall when we finally get to see what school's all about. So looking forward to that and finding out some things myself on this webinar.
Hi, I'm Jeff Harpp. We have a 17-year-old son who has idiopathic pulmonary hypertension. We currently live in Indianapolis, and our PH care team is the wonderful group of people at Cincinnati Children's Hospital. Our son was diagnosed in 2015, so we have experienced the range of elementary school, middle school, high school, and now we are approaching the transition post high school. So we've kind of been through the whole dynamics of childhood into adolescence and adulthood. So I want to thank everybody for taking time today for joining us and participating in this. I truly believe that shared experiences are the best learning opportunities. So hopefully we all can share and increase our learning. So thank you for having me.
Hi, everyone. Thank you also for inviting me to join you all. I feel we're always very honored to be able to speak with you, all, especially parents who deal with us every day. But my name is Melissa Magness. I'm a nurse practitioner at Cincinnati Children's. I have the pleasure of taking care of the Harpp family. I have been doing pulmonary hypertension for about 8 to 9 years now. I've been in pediatrics my whole entire career. So a little over 30 years. Don't anybody tell anybody that, but that's a true statement. And pulmonary hypertension is becoming a great love of mine. So.
And I'm Dr. Rachel Sullivan. I am a pediatric cardiologist and pulmonary hypertension specialist. I currently am the Associate Program Director of the Pediatric Pulmonary Hypertension Program at Vanderbilt University. I'm so excited to be a part of the conversation today, and I'm hoping that this provides all of us with a good learning opportunity. So I'm just going to share a brief set of slides that we have. So our goal with our kind of brief presentation format is just to set the stage to have us all on an even playing field in terms of what is pulmonary hypertension, what are some of the common diagnostic modalities and treatments, and really set a guideline of what of the topics that we'd like to discuss as a group, and hopefully engage in a lot of question and answer format. So just briefly going through pulmonary hypertension definitions. Pulmonary hypertension, as most of us on this call are probably aware, is high blood pressure in the pulmonary arteries, which are the arteries that supply blood to the lung. Here's a picture of a heart where you can see this right side of the heart, the right ventricle, pumps blood out to the lung arteries. And the formal definition of pulmonary hypertension is by cardiac catheterization, with mean pulmonary artery pressures being more than 20 millimeters of mercury, qualifying as pulmonary hypertension. Pulmonary hypertension can exist for many different reasons. There's different subclassifications, but pulmonary arterial hypertension, which is what most of us think of, entails a mean pulmonary artery pressure of more than 20 millimeters of mercury, no left-sided heart disease, meaning there's normal left atrial pressures on the left side of the heart, and a pulmonary vascular resistance, which is a cath-based measurement, being more than 3 Woods units. Often pulmonary hypertension is diagnosed first by echocardiogram, which is an ultrasound of the heart that you can see here on the left. There's many symptoms that might prompt someone to eventually undergo echocardiogram that can lead to the initial diagnosis of pulmonary hypertension. Symptoms can be vague and include shortness of breath, fatigue, sometimes chest pain, abdominal pain, swelling of the legs or ankles, and sometimes fainting can be a first sign of pulmonary hypertension. Additionally, if you're already followed by various medical teams for other conditions such as chronic lung disease, congenital heart disease, or a known family history of pulmonary hypertension, that might prompt diagnosis as well, sometimes even before patients demonstrate any clinical symptoms. As I already mentioned, the definition for pulmonary hypertension is officially made by cardiac catheterization, which your care team will help guide you through the frequency and timing of that testing, but it's performed in what's called a cath lab by interventional cardiologists to directly measure pressures and resistance in the heart.
And again, my name is Melissa. I just want to touch base really quickly on Hank the Heart. He was brought out by our team and it's been shared very all over. You can find him on YouTube, but he kind of goes through pulmonary hypertension and just a quick diagnosis. It's a quick 2-minute video. It's great to share with families, friends, even potentially caregivers. I mean, just to give a quick understanding of PH. Hank will continue to get other diseases, but poor little guy right now just has PH. So, but feel free to reach out, and we'll put that in the link too, so you guys can find that. And then I also just want to touch base on kind of treatments and medications, which are the big mainstay of treating pulmonary hypertension. And this is kind of part where we talked about trying to identify the difference between kids and adults. I think most care providers who take care of pediatric patients and take care of children really try to take a lot of these medications and the way they're given, the size of tablets, or just impact on quality of life. And we take that into an account when we look at treating our patients. So you'll see a little bit of variation on that, and that's based a lot on our good our adult colleagues' research, and then our expertise in this medication. So that's where you're going to see probably some of the bigger differences. I'm going to quickly go through them, but really the big goal for all the medications is that we're trying to vasodilate, or make the blood vessels relax and make them bigger, which makes it easier for that right ventricle to pump against those pressures. So I've got the kind of our initials we use for the class of drugs. The first one being PDE5s. That's a shortened way for us to shorten down phosphodiesterase inhibitors. And that would be either sildenafil or tadalafil. There is 2 drugs in that class. One is 3 times a day. The other one, tadalafil, is just once a day. And again, that's based kind of on size and age of children and when we make those decisions to use those drugs. The class of ERAs is a big old fancy word, endothelial receptor antagonist. And there's bosentan, ambrisentan, and macitentan. So we have 3 choices in that class of drugs. And for people who have experience with that, that's the class that we kind of get linked into making sure we check blood value or blood testing frequently. And or if you have a child of childbearing ages, we start to talk about pregnancy tests. So those are just some of the requirements we have from the FDA with this class of drugs. And then the third one is the prostacyclins. It's a really pretty strong vasodilator, and we're giving you prostacyclins. So that's epoprostenol or treprostinil. And treprostinil, if everyone hasn't heard, but that can be given many different ways. We can actually give it 4 different ways. We can give it IV, sub-Q, you can inhale it, or there's actually an oral version of that one. So you can have that one as a swallow, as a pill. And then selexipag is under what's called prostacyclin receptor agonist. So it kind of sits on the receptors of the prostacyclins and helps make it work as a prostacyclin. It's a little bit different than the prostacyclins, and that's an oral tablet also. And then I do want to touch base on oxygen. We do view oxygen as a medication. It is a vasodilator. Really feel that too, also avoiding hypoxia or avoiding low saturations is a way to avoid having vasoconstriction or tightening of those blood vessels. So we want to keep children as well oxygenated as we can. And we recognize that's one of the probably bigger quality of life changes. Like, again, we do look into this and we make all these decisions based on how sick your child is and how they're doing, and try to decide which medications are right at that time. But oxygen, we know, is a big quality of life. And Jeff, I think, will address that a little bit later too. He has some strong feelings. So we do know that. And then lastly, from a medication standpoint, there's always a hope that something new and upcoming is coming out there. And so I'm sure there's been a lot of noise in the community about sotatercept. And that's another medication out there. It's a sub-Q injection, and it is in study for pediatrics. The adults have kind of completed their studies, and it looks like some good promising disease process help for pulmonary hypertension that it's giving us. So it's on the BMPR2 pathway, but it's kind of balancing some growth promotion and growth inhibiting. I don't have my tag words down very well for this one still yet, so we're still learning about the medication. So that's kind of our medications and treatments. And then we also did want to address kind of like what to expect when you come to see us. And that could be either inpatient setting or an outpatient setting. Maybe on diagnosis, you're going to see us an outpatient and then have an admission right afterwards and have to stay for a period of time. But testing wise, echocardiogram, EKGs, some kind of walk testing or exercise testing is always going to be expected. Pulmonary function testing and lab draws. And granted, each center has probably got a little bit different variation of where they feel comfortable, the timing of those, whether that's something you see every time you come to see us an outpatient, or if that's something that's every other visit. So that is usually per your provider's choice and their comfort level. And then really from expecting who to see, you could see all these people in this huge list, or you could see a couple of those people. I would say different centers have got a little different variation on that too, like who you're going to see every time. You may not see everyone, but just know that they're always there, should be at every center as an option. And I think Jeff and Jayna will talk a little bit more too about psychology and not only for your child, but for the family, and just really trying to support the whole team, your whole family through this process and dealing with pulmonary hypertension in your family. And that's really what we say. And then you may have one person affected in the family, it does affect everyone. And then I just really want to encourage, use of also child life. So if you got an inpatient stay coming up, or even an outpatient stay that you have a lot of stressors, there is people there to help you out. And then the next one, we really talked, some of these came from some of the questions we already got pre-presentation, but there's been a lot of questions about how to talk to your teachers, how do you talk to pretty much anyone, if you're seeing the emergency room, like how do you talk to people? And I think what I really want to emphasize the most is that trying to understand your child's disease and understand like the symptoms that they have and the things you should be worried about. And then getting that from your medical team and getting a good handle on that. And then you being an advocate at wherever level you are and needing help. So whether that's in a school area, then you get to be and helping educate other people out there. But we've kind of really put together like when to call, any change in activity or appetite, missing doses of medications, losing lines, losing sub-Q sites, those things obviously are going to call. Any illnesses, touch base. Your team may not need to see you, but maybe have you to see your pediatrician and follow up. But then times to really just to seek immediate care, be shortness of breath, chest pain, fainting. But again, this is really good things to talk through with your team to get a good understanding of what is their red flags and which things they want to hear from you and when do they want you to come on in. And then I'm going to hand over to Rachel again a little bit to go through talk about our outline.
Yes, and apologies if you can see both the slide share, the presenter view. I'm not sure why, but anyway, thankfully we're not going to be on PowerPoint most of the time to make this more of an interactive discussion, because our goal is really to provide a good set of questions, answers, and really engaging conversation about how to live life with pulmonary hypertension. So the main topics we really wanted to get through are navigating school, because we know that can involve a lot of challenges and hurdles to jump through when sending a child with complex medical care to school, day-to-day activities of having a child with pulmonary hypertension, and really how to support both the patient and family to encourage well-being and supporting good mental health for all of those impacted by a diagnosis of pulmonary hypertension. So we'll try to answer questions as we go. We'll also have time at the end for kind of an open question and answer format, but we'll kind of divide it with a goal of having equal time spent on all three of these topics. So I'm going to stop sharing.
Yeah, before we go on, Rachel, there's a quick question in the Q&A. So I want to touch base on that before we go further, because it was talking about FDA approval for PH and medications. So the question was tadalafil, macitentan, epoprostenol, treprostinil, and selexipag. Do they have FDA approval? The answer to that is no, those medications do not have what we say FDA approval. We're using them in an off-label use, which means kind of what I said earlier, we take a lot of the adult data and stuff and apply it to our kids with very good experience. I will tell you, there is studies out there though, in those. There was one tried for tadalafil. I don't think they've ever recruited anybody. Macitentan is in study in pediatrics, and so is selexipag. So those and may get asked frequently by providers to join studies if we can get you into them, because that's what we really like to do, is have as much studied medications out there as we can.
Agree.
All right, sorry to interrupt. Go for it.
Yes, so I think we were hoping to talk about school first. So I think a nice segue into this is really to get a sense first from Jeff and Jayna about their experiences with both being in physical school as well as homeschool settings and how to support your child in those environments.
Thanks, Rachel. This is a parent's terrifying nightmare, is to release them out of your care with a chronic illness and shift the responsibility and the guidance to other people. It's certainly a terrifying experience that my wife and I have evolved through, and this has been a evolution as we've gone through different schools, like I mentioned, from elementary to middle school to a bigger school and then into high school. And some of those challenges have changed from school to school, and we've learned quite a bit over that time, and some of the pitfalls and some of the highlights. But it also evolves as his condition progressed too. So some of our challenges initially in elementary school were just making sure that the nursing staff and the teachers and the school administration was aware of his condition and some of the things that our care team outlined for us to bring to attention. So we were kind of learning it in that phase of what our physicians and our care team thought to highlight on, and then what we also, my wife and I, would come up with. And initially that was just the signs and symptoms of PH and blue lips and fainting and those sorts of things. In elementary school, he was in one classroom with one teacher, so those were easier challenges to navigate. He wasn't walking across the school or anything like that, and he wasn't on oxygen at the time. So elementary school, we had it buttoned up with an IEP that was developed early on based around his accommodations. And his emergency care plan that we set up with the school nursing staff. So there was a lot of fear from the nursing staff and teachers around this and how to act appropriately and what to do. I think there was a lot of apprehension, but those things kind of moved on. As we went into middle school, now we're talking about moving larger distances, and as his progression progressed, navigating that distance that he could do. So again, the challenges were helping him, keeping classes close together, giving him time to move, and all the things that come with that. High school was a lot greater jump because now he's changing levels of school and lunchrooms. And so we work with the school again to get in his basic IEP accommodations. But we also learned what was important to Cash too. And Cash isn't our son's Cash. Cash is not the best self-advocate. So what we thought was important to have into his IEP and his emergency care plan weren't necessarily the same things that he was wanting to have in school. But in the short list, we found that it takes him a little bit longer time to walk from class to class. And during this time, he was placed on oxygen. And as Melissa mentioned earlier, navigating the oxygen company is absolutely abysmal. And he was on tanks, moving in an E-tank. I don't know, that's the big scuba-sized tank from class to class. He's in school part-time. That's basically all he can really tolerate going to at this time. In elementary school, he was able to tolerate going full-time. In middle school, now he's at part-time. So the strategies around oxygen, navigating an oxygen tank around a big school with a lot of people in the hallways, we put in place to allow him to leave class earlier, where he has an opportunity to move from class to class. Also, dealing with medication side effects and medication too, we had to navigate that with our staff at schools, and nausea, vomiting, and those sorts of things early on in the process were large side effects for him. And, the ability for teachers and staff to understand that when he needs to use the restroom, he needs to go now. Or if he needs to go to the nurse when he's not feeling well, he has carte blanche access to do all those things. Lunchroom help, he really, tries to fit in as much as he can. So those accommodations really he bucked against that we thought were important. But we also met with our school to try to lessen the distances between classrooms for him too, because we didn't want him to have the burden of carrying an E-tank from one side of the building to the other side of the building. And that is difficult to do all the time. But the school is willing to provide a wheelchair for him to be pushed from class to class, which obviously that was not very popular with Cash. But this has been evolving for us, and navigating this, and in the changes, I will say, from school to school and age and progression are going to leave you on your toes. And just to highlight that there are some things that we miss out in terms of making Cash's quality of life easier at school that was just brought to our attention recently. I had a conversation with Cash, and he had mentioned that he had a fire drill. And unbeknown to my wife and I, we didn't understand, like, okay, well, how did that work out? And he goes, I was terrified. So I didn't think that I would be able to safely get out of school quick enough if there was a fire or an emergency. And I said, that's something that the school contingency plan has for, but I addressed the school directly. And I said, what is the plan for an emergency situation in the school, or God forbid a shooting, right? How can he quickly get out of a building safely? And they mentioned that there is a chair that they can provide to move him quickly. And then I asked, where is that chair? And it's like, it's in one side of the building. And I'm like, that doesn't meet our needs. That doesn't meet our expectations of getting our child out safely. So they've purchased other chairs to be strategically placed around the school. and their disabled population. So long story, I know it's kind of convoluted and I really didn't hit on a whole lot, but there's things that your care team is going to guide you in, and Melissa's guided us on the big highlights, but also putting yourself in your child's shoes too. And that's something that my wife and I try to do every transition. And self-advocate is, that's a big part of this too. We try to fight as hard as we can around every issue that we think is important to our child, as we all do, and having a care team to back you up when those inevitable challenges meet. So that's the long and short of it.
Okay, so I'll talk about Jackson a little bit and our experience with homeschool. So again, he was diagnosed when he was 14 months old, so he wasn't in school yet. He was daycare age, and they basically told us he cannot go to daycare. So I quit my job and started staying home with him, and that the reasoning for that was to protect him from germs. They were concerned about RSV and flu and everything, putting him in the hospital and making him worse with his pH. So that just kind of naturally transitioned in as he got to school age into us homeschooling. And it worked really well for us. He is on a sub-Q pump, so he's on subcutaneous therapy. And so for having him on a pump and then multiple oral meds every day, it made us feel more comfortable, him being at home, plus, protecting him from more exposure to germs. So it just naturally transitioned into us homeschooling, and it's worked really well for us. And he now has started expressing in the last couple of years interest in going to school. So we have talked about it, and it's, I kind of feel like we have to advocate for our children. We have to let them do, to some extent, what they want to do, and just help them accomplish those goals. So we have enrolled him in a private school, but my guidelines were kind of, it has to be close by, because just like Jeff was saying, he also struggles with nausea and has, side effects from his medications. So it's, if I have to go pick him up, I don't want to be driving across town to do that and him sitting there waiting all day for me to get there. So if he has a site get pulled out, that's kind of an emergency situation. So it needs to be, something that I can address quickly. And those are things that we're also going to have to discuss with the school. And just like Jeff was talking about, get a plan in place and have these, make sure that the school is educated to know what your child needs. And they're not going to know that if you don't advocate for them and you don't tell them what your child needs. So it's very important as a parent that you step into that role and you communicate with your care team and you find out what are the plans, the IEP, the 504 plans. What do I need to have in place to help my child to do the best that they can do in a school environment? That's about all I have.
And I'll add, as someone on the care team side of things, I think each family's decision about going to school, doing, homeschool, all of that's a very personal decision that we as care providers, I think, are more than happy to support whatever makes you and your family and your child the happiest. We know that everyone's situation is very different. It's tough when kids go to school. There are more germs. There is no way of getting around that. And working with your care team to figure out truly what is your child's risk in terms of pulmonary hypertension, getting sick, is an important part of the conversation. And that's one of the things that we went over in terms of when to reach out to your healthcare team. I personally like to know, even if it's hey, I just want to let you know my kid has a cold, because then we can keep tabs on it and help guide when you might need to come in for a clinic visit or come to the ER, especially because infections, especially if you are in a school or daycare settings, are in some way inevitable. And it does look like we have a question.
Yeah. You got it? You want me to read it?
I got it.
Yeah.
All right. So I think we'll start with the first one. Have you sent your child to school, or do you plan to, with a one-to-one nurse from an agency? If so, why or why not? No, either of you have any experience with that?
Yeah, I don't, that wasn't really considered from us. You know, we did meet initially in elementary school when he first, after our diagnosis, and then medication and treatment. We thought about that, a one-on-one situation. And initially we did have somebody, not a nurse, but an extra set of eyes on him when he was on the playground or he was in the lunchroom, where somebody was monitoring him. It wasn't specifically a nurse, to answer the question. But we thought that was appropriate in where he was in his disease progression and his age. So that was one thing that we initially put in place. To answer the question on, you know, the concentrator versus traditional oxygen, I could tell you this, is that it depends on your provider. And for us, we didn't have a mobile concentrator option. And I could tell you that Cash goes to school part-time right now on an E-tank. And an E-tank would last basically through 4 hours of school. However, that size is extremely burdensome. Like I mentioned, it's the size of a scuba tank. So navigating that through school in classes is not easy. Now, the mobile concentrator that we currently have now is way better in terms of being able to operate and navigate school, but it lasts for about an hour and 45 minutes on the battery that it has. So now the challenges were, okay, we need to position Cash near outlets so he can plug in his concentrator because it will not last the whole time. And then, you know, taking that in and, you know, in and out of outlets, I can tell you from his feedback, it is an extreme game changer of having a portable oxygen concentrator versus an E-tank. By all means, he is way happier going to school in that situation. We do keep tanks in the nurse's office, and as a backup in case something was to happen to his unit, we do have those. And we, you know, obviously made sure, I forgot to mention, but nurses have the appropriate pulse ox and blood pressure cuffs too. So anytime he doesn't feel well or anytime he needs to go to the nurse's office, those are the first things that they do when he gets there, is to get him laying down and then taking his oxygen level and blood pressure. Hopefully that answers the question.
Yeah, and Jeff, the only thing I'd back up with the oxygen, the tanks versus the concentrators, it has to do with size too. Like if you're a younger child, the concentrators don't always work because some of them are the pulse, which means they have to initiate the breath. So there's a lot of, and I didn't mention that when I was talking about oxygen, but that's part of the problem too. And Jeff is very well aware, he's helping at PHA level to argue about oxygen accessibility. It's just, we understand that it's a really big issue right now too. So I think that's part of the problem.
I think one of the last parts of this question, there was many excellent parts of it, is Jayna, was there a specific reason in terms of choosing private school? I think that is more getting at, were there specific qualities in a school, especially having kind of made a decision to go from homeschool to choosing the right in-school setting?
Right. For us, it was because it's a Christian private school, we wanted him to be in a Christian environment. It also is a smaller school, so we aren't going to have as big of class sizes as in a public school. And again, it's 5 minutes from our house. So all of those, like, you know, weighed in on our decision.
Awesome.
There's a diet question. You see that, Rachel? I was looking to see, we did have a previous question about, sorry, I'm looking at some of our previous questions we had. There was a question about food, and so I was trying to pull that up at the same time.
Yes. So I think that this question is, how about diet? Are there any special snack options for school days? And one of the registration questions about specific diets for pulmonary hypertension, especially for kids, is, does that help you grow out of pulmonary hypertension? And I think it's a tough answer to apply to every individual scenario. One of the populations in pediatrics that might have pulmonary hypertension is those who are born prematurely and have chronic lung disease related to prematurity. And I'm not sure if that's what the question was getting at, but in some of those patients, growth and time can allow those particular individuals to potentially outgrow their pulmonary hypertension, but that is not the case with all types of pulmonary hypertension. And for instance, pulmonary arterial hypertension, whether it's due to a genetic cause, idiopathic cause, meaning we don't know why, diet is generally not felt to significantly alter the course of pulmonary vascular disease. What I will say, though, is that having good nutrition, meaning adequate growth, is very important and definitely can impact patients' energy levels and how they do with tolerating their disease. So one of the things in my mind is, what will your child eat in terms of what is the best? Certainly having a good variety of nutrients, proteins, carbohydrates is very important, but some of it is just what works. And that's where nutrition can be a very important part of our clinic visits, because some kids do need some supplementation, whether it's some extra supplements by mouth. Some of our kids require supplemental feeds by different means, such as a G-tube, but it's not a one size fits all, which does make it tricky.
I think especially if you're talking to a school setting, and I'm curious, Jeff or Jayna, for offering snacks during school program, and especially if you have kids who are heavy loaded in the morning with meds and may not feel like eating, having that conversation, they should be allowed to have snacks. That becomes a conversation of what works best at different schools, allergy type things, exposures. But I think that's always another thing to add to your booklet to ask for special dispensation.
Yeah, I'll add to that, Melissa. I forget what medication it was, but we were on the calories before. What was the medicine Cash was on? One of them, he had to eat.
It was the oral treprostinil.
Yeah, 200 calories, and that overlapped into school. So being 9 years old, or some of the younger kids, getting 200 calories before medication can be daunting too, and can be a struggle to get that calorie count in. So we found the most calorie highest, easiest thing to do, and that was milk was one component of it. So that was like 80 calories, and you had to do, or 100, whatever it was, for a cup. But our school was very, very understanding, and like you mentioned, Melissa, we did put in those accommodations for food or drink at any moment. So there wasn't any time in any classroom situation where Cash wasn't able to drink or eat anything he wanted whenever he needed to. And we didn't get much pushback on that.
Yeah.
Other things we did.
Yeah. I'm going to come back to I'm going to stay on diet for a minute. I'm looking at the Q&A. I'm going to skip one for a second, but G-tube feeds versus GJ tubes. I have a little thought, Rachel. My G-tube feeds, the only risk is it's still going into your stomach. So it's a tube that's into your stomach. Yeah. So the biggest concern when you have somebody with pulmonary hypertension, as long as they're not aspirating, like they don't have a lot of reflux back up and get it into their lungs, that would be another risk factor for some vasoconstriction. Because the question was, a GJ tube, which gets it past the valve that would allow you to throw up. So I don't necessarily, and Rachel, have you experienced it in only case that we would have somebody that we're really worried about aspiration, will we go that far with a GJ tube?
Correct, because the GJ tube also requires nearly continuous feeds, which can be similar to carrying around an oxygen tank, a big quality of life thing for both patients and families, especially depending on the age.
And then Jayna, there was a question here about, which I've heard also, private schools aren't legally required to file the 504s, but they are required to file IEPs. And I think there is a little conversation. Public schools historically have a little bit better resources, maybe. Jayna, did you look into that when you were looking at the two different and trying to make your decision? And
honestly, no. I mean, we knew we wanted him to go there, so when we got him in, we were happy. So that's a bridge that we're going to cross, but they've basically told us that medically wise, they will come up with a medical plan for him. And if they sounded like they would be very accommodating. And I think, going back to the food and the eating, Jackson eats all day long. That's one of the things that I've seen, like, as a joke for homeschool. The most expensive thing in homeschool is feeding the kids because they eat all day long. So that's going to be something that I hadn't thought about, that we'll have to make sure we're sending him adequate, amounts of food for him, because sometimes when he does get nauseous, some graham crackers or something like that is our first thing to try to kind of settle his stomach. So that's definitely something I'll have to think about. Oh, and one other thought. This isn't exactly diet related, but when Jackson was very newly diagnosed, we dealt with a lot of vomiting. To the point where it was almost every day. And so I think it's very important to communicate with your team, even something that seems kind of minor like vomiting, because that is a loss of nutrition. And that's not a good quality of life. So we had to work with our doctor, and we finally figured out that his diuretic needed to be adjusted. And when his diuretic was in the right range, he was less likely to, it's almost like he was overloaded on fluids, and then it would just come up. So just if you're experiencing anything like that, just go to your team and figure, out a good plan. And sometimes it may require adjusting medications or adding medications. So just wanted to point that out.
Well, Rachel, you're reading that one. I'm going to throw out, Angela is posting a bunch of things. A lot of us use the PHA. There's some really good resources on, there's a school resource packet that PHA, it's been clinicians who've helped develop it, but, and medications, all the meds are up there too. So it's a really good, nice, if you guys haven't found that spot on the PHA, she's posting them all in the chat. It's a good place to start too. I think it gives you some good, just solid foundation to then take it into people that you need to discuss and be advocate for your children.
Yeah, the resources we've utilized a lot, as well as your team input too. And like I mentioned earlier, this is it evolves, and needs change, and situations change, and this is the opportunity to share best practices and kind of anticipate some of the shortfalls, and that in turn our input helps our care team too to be aware, and other parents that we engage with. So yeah, those are great resources that PHA provides.
Jeff, there's a question that maybe you can answer. Are the children attending school wearing masks the entire time?
Our school did, and before COVID, and well, right as COVID was happening, we immediately talked to our care team and Melissa in Cincinnati to help us navigate that situation, because again, this was a terrifying situation. And we have vulnerable people, vulnerable kids, our own kids, everybody, but everything that decisions that we made were based around input that we got from our care team. So we officially just said we're done with school for this period of time, and we kept them out of school. Our school went virtual in Indianapolis during that period of time too, and then we kept him even after the restrictions of in-person school lifted. We kept him home too. And it extended after that, and after vaccination. And again, that was something that we deeply had a conversation with our care team around too, is going, what are your thoughts on this? Is this something for a child, when we could get to the age of that, is this something appropriate? And they gave us their best educated answers to guide us in that respect too. Then as things lifted, our school required masks for a period of time too. And it's not easy for us healthy adults to wear masks for extended periods of time. It's even more miserable for kids that have to gasp in for air when they're walking around or moving. So it was really miserable wearing a mask for him. Oxygen helped with that somewhat. And as everybody, we were always worried about infections in a school situation, and especially around a pandemic. And Cash has a younger sibling too, and that's another disease vector avenue too that we were worried about. And our son did get COVID over the pandemic time, and thankfully we were blessed that he really didn't. He was tired basically, but we were absolutely panicked, no doubt about it. Panicked.
I think it's always a hard question. We use the word, and I don't know if Rachel, that's how we can't live in a bubble, right? You've got family who's got to work. You have people who, children who have to go to school. So I think you try to balance that at what, keep an eye on your area. If the diseases are up a little bit because this could be anything but COVID, maybe limit your family's exposures. So, don't go to the roller rink or
there's a lot of things that Cash can't do, and there's some things that he really values, and he really values going to school, even though he's not an extremely sociable person. That's very important to him. He enjoys going to school, and that was something that we were going to weigh the risk versus his desire too. Those were weighed by my wife and I too, about going, is this something we can do? But ultimately, we felt comfortable enough to get to the point where even when masks were lifted, I think we probably kept him in one, but he fought us pretty hard. And being a teenager, that was just a hill not to die on. So
yeah. I get this next question, I think kind of goes into that. I don't know if Jayna, you want to take the lead on it, but just talking about psychological factors, trauma from procedures. And I think I could just say anytime some kids come to the hospital, there's something linked with that. And if your situations with the child, but also with siblings, you talk a little about that and how you guys deal with it.
Sure. So with Jackson being on subcutaneous Remodulin, we have had to deal with a lot of anxiety. He gets, even at almost 12 now and being on sub-Q for almost 10 years, he still gets very anxious prior to a site. We just try to kind of empower him as much as we can, give him choices like, okay, where do you want to put the site, your right arm or your left arm? Can we do it right here? Is this okay location? We let him, when he was younger, we would get like a prize box. So if he was, gonna get a new site, then he would get something out of the prize box. So as we're like out shopping and he sees something he wants, it would just be like, okay, well, let's put this in your box. So those kinds of things would help with bringing down his anxiety. We also pray before every new site, just to kind of, help him in any way that we can to bring in comfort. And as far as siblings, our siblings, because of seeing what he goes through, are just some of the most compassionate kids you could ever imagine. His 7-year-old brother will, like, even from a younger age, even when he was younger, would go and grab the treasure box and bring it in there. And Jackson, do you want this? Showing him things, trying to help with his anxiety. The little one will come and hold his hand when he's about to get a new site. So it's just definitely increased the compassion in those two, watching what their brother has to go through. I don't think they necessarily have any fear or anxiety as far as going to the doctor or anything because of what he's been through, because honestly, it's never been that scary for Jackson. It's just how he grew up. So since he went to the doctor so many times from a young age, it was just kind of, he grew up going to the doctor, and they always kind of made it fun. They had a treasure box, they child life, and the arts and everything that they would put on at the hospital. So we just always tried to let him know what was going to happen. And like I said, give him choices if we could, and try to make it fun and give him like some sort of positive reinforcement to help.
Yeah, I'll quickly touch, there's some things that Cash that he absolutely despises, and there's other things that he just doesn't really care about. I can tell you that IVs and needles do not bother him one bit. What bothers him is being put to sleep. He absolutely hates the feeling of going down for a heart cath. This is largest pain point. That and being hospitalized. Everybody's there, but there's just things that are unavoidable, and we try to navigate that the best we can through strategies Jayna discussed, and those have evolved too over time. But I can tell you that the situation is tough, and it's tough for kids, and it's tough for siblings. And my wife and I continuously deal with the guilt that goes along with Cash's sibling, that the attention and the resources that we put into Cash, it's not equitable, right? And we try as much as we can try to make that equal. It's difficult to do, and it's a burden for Cash's brother, and no doubt about it. And it's something that you need to be aware of, and I think all parents in this situation are aware of. And we're still trying to figure out what that looks like to make that right, if you can. But it's disrupting the sibling path, schedule that is tough, because their world gets upended around everything that involves Cash, their schedule, everything. So we try to minimize that disruption as much as we can, but we rely on the community and, parents and family and all those other things, but it's just not the same. So hopefully there's somebody out there that listening or watching that can provide some good strategies that they've done too. So we're way learning on that curve too.
Angela did post there is a peer mentorship that PHA kind of tries to do that might be helpful. And I can't encourage them enough. Hopefully most of your providers have some access to, sometimes it's child life chaplain. If you can get in any kind of behavioral medicine by psychologist, and that's not just for the child, but it's for the whole family. So that's always my application that we throw out a lot. We are getting close to time, so I want to make sure I hit everything. There was one question, there was a couple questions that we were previously asked. There was a question about sub-Q management and adhesive allergies. Jayna can speak of that, but I think we've learned a lot that families can share a lot of that stuff together. They come up with great alternatives. We could also post, there's some APNs across the United States put together a booklet, which we can put up on the chat too, that kind of gives some hints and tidbits. But Jayna, you want to hit that real quick in a minute or less?
Sure. So, and
no pressure.
That's okay. I just saw another question coming in about managing the pool and beach with sub-Q. So I'll try to get both of those at the same time. So yes, sub-Q is definitely hard. It's hard on the skin. We have learned a lot over 10 plus years of doing it. One thing is the type of site. There are several different types of site. Our preferred site is the quick set. We were initially on Clio and started having a lot of issues with Clio. We tried the Silhouette, had leaking issues on the Silhouette as well. So we finally ended up on the quick set, and that's been the one that he's probably been on for 7 years. Something that we do to address the adhesive irritation is that, and this is something you should discuss with your team before trying, but we do a extra thin duoderm under his site. So we put that as kind of like a barrier, and the duoderm kind of prevents the site from laying directly on the skin, and that helps his skin to not break down as fast with the duoderm layer there. I know it's worked for some people. It doesn't work for everybody, but it's worth trying. As far as pool and summer, we usually use his lower back or upper butt for wintertime, and then we switch to his arms. And there are a couple of options for sleeves that you can get, waterproof sleeves. There's some on Amazon that are specifically for a PICC line, but they're able to be used for a sub-Q site. Then there's one made, the name of it is failing me right now, but they also make dry suits, and they're made in the UK. And you can get one specially fitted to your child's size. And that is great for swimming, for showering, for beach, all of those things. We usually waterproof underneath that as well, just to make sure that if it were to leak, that the site and the pump are still protected. The site and the pump are inside of that waterproof sleeve. And then for kids on like an IV, there is a full body dry suit that is an option for protecting their IV, their central line, and their pump, because that pump is quite bigger. What did I miss?
I think that's good. The one thing I steal is a lot of the diabetic stuff too. Like some of the sensor dressings, we've had some really good success for.
Right.
So I would tell you, as a provider, the parents come up with great stuff. So I just beg and borrow from each of the parents. So as long as you guys try to share and share alike is really what helps a lot.
And there is are we sharing? Okay, that sub-Q remodeling guide that was shared in the chat, that is a very, very good resource. I wish we had something like that when Jackson was first diagnosed, because it has all been just, a lot of it was learning from other parents, and then some of it was just figuring stuff out. But Jackson wears his pump in like a little fanny pack type belt, and it's under his shirt, and you never, like most people don't even know he's on a pump because they can't even see it. So and then we wrap his site up on his arm with an ACE bandage just to add that additional protection. He is a boy, he has 2 brothers, and there is lots of horse like roughhousing in our house, and you know, that helps to protect his site. So just do everything you can to protect that site.
Quick question I can answer about Remunity. Yes, there is kids on Remunity pump, the new sub-Q pump. It is doable. It works on kids. It's got some of the challenges that are different than the CAD MS3, and reach out to your provider too, I guess, on that one. So. How we doing, Angela? We're trying.
We are good. We are right here on time at 1 minute left. So I would like to just put it, are there any last thoughts for families or caregivers that you would have if anyone wanted to just take the lead, like just one message of hope before we end for the day? Anything you felt like you weren't able to say or would like to add in before we leave for the day?
I'll quickly say that there's a lot of things that we can't control in our child's situation, a lot of things that we would like to be able to control. What I've found and what has brought me a lot of value and purpose is volunteering and being a part of some of the Pulmonary Hypertension Association's initiatives. It has allowed me to direct some things that I can control and some things that I can help with in this situation. And I'm grateful that Angela and others at PHA give me that opportunity in that purpose. And that is something I would encourage any parent to do. And it could be as much as or as little as you want to be involved. But I can tell you what you get back and what I've gotten back is tremendous.
Just to piggyback on that, we do a yearly golf tournament to raise money for PH, and that is something that has kind of empowered us. It makes us feel like we're doing something. It kind of gives us purpose, and we have a sense of accomplishment after every golf tournament. It has also helped us to get word out about pulmonary hypertension because a lot of people don't know about it. So it also helps us spread awareness. And so just by, like Jeff saying, being more active in PHA and just doing something to kind of feel like you're doing something, that just really helps with your mental health. And if you're not in the capacity to do something like that, you need to take care of yourself. You need to find time to do something that you love. Get a family member, get a babysitter, take care of yourself, because you can't pour from an empty cup.
Ask your care providers. You should, and a lot of these questions are coming up. You should be able to ask your care providers. And if they can't answer it, they should find somebody to give you the answers on most things. And number two, don't forget PHA also has conference, correct?
Yes,
Which is amazing. It's next year in Indianapolis. That's also for families and providers. It's a great time to be mixing with all of us. And you can ask a lot of these same questions very informally.
Thank you.
And I couldn't echo what Melissa said more, that please talk to your care team. For us, it is really such a privilege to be a part of all of our patients and families' journeys. And unless we know how things are impacting your life, we can't help. So as outlandish of a question as it may seem, please ask us. And certainly we love to help find answers, even if we don't know it right off the bat.
Thank you so much. I would like to also add that PHA is hosting the PH Community Workshop in Boston. So if you are in Boston or the surrounding areas, on July 29th, we will be there for a free full-day workshop where we will have breakout sessions on pediatric PH. So please look for that on our website. Thank you to our panelists. This was so informative, and I think I can just see from the messages that were coming in that people were able to gain a lot of information from what you shared. Thank you, Jayna and Jeff, for sharing your story and sharing your family's story with us. And then Dr. Sullivan and Melissa, thank you for providing your expertise and empowering the people who watched and attended live. We appreciate you donating your time to give us this valuable information today. Lastly, there will be that survey that pops up, but thank you for joining us. I hope y'all have a wonderful afternoon. Bye.
Thank you.